Welcome to our final session of Nutrition Live for 2025. We are thrilled to welcome so many healthcare providers. So my name is Renee Welsh. I'm one of the program co-directors along with Dr. Kirby, and we're so glad to see so many providers here on tonight. And a huge thank you to the over 735 healthcare providers joining us from 67 countries. We're looking forward to a great presentation tonight, and I'm going to hand it off to Kate Patten, who's our moderator for tonight.
Hi, good evening. Excuse my voice, I'll do my best here. I'm happy to introduce Dr. Suraju, who's one of our associate staff in preventive cardiology here at Cleveland Clinic and a researcher within Cleveland Clinic Coordinating Center for Clinical Research. Dr. Suraju trained at Stanford University as a resident and chief resident in internal medicine, where he later stayed for his fellowship and as a chief fellow in cardiovascular medicine. Then he completed a postdoctoral research fellowship funded by the American Heart Association focused on health tech and innovation. We are lucky to have him move further east and join us at Cleveland Clinic in 2002, where he made a really big impact. And just 1 year later, he received the Top Educator Award at Cleveland Clinic in 2023, which is only given to a small number of faculty. While I have not personally worked with Dr. Suraju, I have had the pleasure of working with registered dietitian Julia Zampano in the past. We worked together in preventive cardiology for about 10 years, and Julia has been there now for, I believe, 20 years. She is an immense wealth of knowledge, which is why she is the media liaison for our Center for Human Nutrition. I have learned a lot from her, and I know how passionate Dr. Suraju and Julia are about this topic, so I will let you take it from here.
Wonderful. Thank you very much for that kind introduction. Thank you to the organizers, and thank you everybody for joining us for this session. And without any further ado, let's get started. And I'm going to share my slides here on session number 6, which is titled Nutrition for Cholesterol Management. And both Julia Zumpano, my colleague, and I are absolutely delighted to be here with you today. Here are our disclosures for your review. But the learning objectives of this presentation are summarized here. In a nutshell, we're going to describe the clinical management of common presentations of cholesterol disorders, where nutrition fits in. We'd like to discuss the role of nutrition in mitigating hypercholesterolemia, managing hypertriglyceridemia, and focus a little bit on topics that may be of high interest both to patients and providers and clinicians, including processed and ultra-processed foods and specific dietary patterns that are recommended in cardiovascular management or are of high interest for patients who may be interested in gaining opinions about these diets for cardiovascular health. And the way we've structured this is with a case-based approach, really to ground the discussions in patients that we might see. So let's just go ahead and get started with our first topic. We're going to talk about high LDL cholesterol. Here's quite a simple case. A 68-year-old man presents to preventive cardiology clinic because of a high LDL cholesterol level, which is 150 milligrams per deciliter. He would like assistance with managing this level. How do we manage this patient? Now we come to our first polling question of the day. Of the below, which lipid value is arguably the best predictor of major adverse cardiovascular events? Please go ahead and if you see a poll, go ahead and vote on the poll.
Majority had voted for LDL cholesterol.
Excellent, excellent. They're showing up just now.
65%. Okay.
65%. Beautiful. I see that. 65% have voted for LDL cholesterol. And non-HDL cholesterol is in second place, and the voting is now closed. So non-HDL cholesterol is actually the biggest predictor of cardiovascular events. It's not actually LDL cholesterol. This is a tidbit that's important to know because although we're talking about LDL cholesterol, for the most part in this case, non-HDL cholesterol encompasses all the apolipoprotein B containing particles, which are causal of atherosclerotic cardiovascular disease, namely heart attacks, strokes, etc., and encompass not only LDL, but also triglyceride remnants and lipoprotein little a, both of which are hot topics in cardiology we will all be hearing more and more about. So, high LDL cholesterol. One of the first steps here is to establish the treatment goals for this patient. Now, when you see somebody and their LDL cholesterol is 150, we need to know what we're treating to. And a good reference for this is the 2022 ACC Expert Consensus Decision Pathway on the use of non-statin therapies, which note that for secondary prevention, meaning if they already have established heart disease, or high-risk primary prevention, meaning they have lots of risk factors for heart disease, we want to lower that LDL cholesterol to less than 70 milligrams per deciliter. So that's more than a 50% drop for this patient who had an LDL of 150. For high-risk secondary prevention, the LDL cholesterol goal gets even more aggressive to less than 55 milligrams per deciliter. So in this patient, to give us a little more history, this patient had a prior stent to his left anterior descending artery, hypertension, chronic kidney disease, and his LDL cholesterol goal ideally now ends up being less than 55. So we're talking about a massive drop in the LDL cholesterol. Now, we of course go through the medication options. That's our job. Ezetimibe, PCSK9 inhibitors, bempedoic acid. He is unable to tolerate statin therapy, but he needs nutrition counseling, and he's interested in approaches that decrease LDL cholesterol levels through nutrition. And this is where we have a close partnership with our colleagues in the nutrition world. And here, let me turn it over to my colleague, Julia Zampano, to talk to us a little bit about nutrition strategies to lower LDL cholesterol. Julia.
Thank you so much, Dr. Suraju. So we approach LDL lowering from a dietary perspective in many different strategies, but these are the most common 4 strategies I would say that I use. First of all, reducing saturated fat and trans fats. We look for even a 10% reduction can lead to a 10 to 11% reduction in LDL. So you can make an impact with really looking at honing in on those saturated and trans fat foods. Increasing soluble fiber. So for every 1 gram of soluble fiber can lead to a 1% reduction in LDL. So you have 10 grams of soluble fiber, another 10% reduction. Phytosterols in the form of a supplement, you can gain a 10 to 14% reduction in LDL. And then weight loss, anywhere from 5 to 10% of your current body weight can produce some reductions in LDL. So saturated fat guidelines, according to the American Heart Association, they suggest less than 6% of total calories. So that equates 12 grams for a 2,000 calorie diet. The dietary guidelines for Americans suggest less than 20 grams per day, which is a little closer to the 10% of total calories based on a 2,000 calorie diet. Now, we know food sources of saturated fat include processed red meats, processed cheeses, snack foods, commercial baked goods, fast foods, deep fried and breaded foods, not to mention baked, even homemade baked goods, or any of those, packaged foods are going to contain saturated fat. And these are also food sources that will contain trans fats. Now, saturated fat that can be included in moderation is some dairy fat, leaner cuts of red meat, some egg yolks, dark chocolate, maybe even a small amount of coconut oil. Now, soluble fiber, we aim for 10 to 15 grams per day. Food sources of soluble fiber include grains such as oat and barley, legumes, dried beans, peas, and lentils, nut butters and nuts. So walnuts, almonds, mixed nut butters, seeds such as chia seeds, ground flax seeds, hemp seeds, and pumpkin seeds, vegetables like sweet potatoes, broccoli, carrots, and Brussels sprouts, and then fruits, of course, bananas, apples, pears, berries, and avocado. Now, these are specific ones that are high in soluble fiber. All fibers are good for us, but when we're targeting LDL reduction, we really want to look at soluble fiber. And we can also use a soluble fiber supplement if that's something you want to consider, like a psyllium husk fiber. Phytosterols, next up, to help lower LDL, and they are naturally occurring compounds in plant-based foods that mimic cholesterol and block the absorption of cholesterol. So they, as I mentioned, are quite effective, 10 to 14% reduction in LDL for those who tolerate and do well with them. They're generally very well tolerated. But the issue I think that I've found most with patients is actually getting to the goal dosage, remembering to take the supplement 2 to 3 times a day. So ideally the goal dosage is 2 to 3.4 grams in a supplemental form. And that typically equates to 2 capsules with meals. So generally 2 with lunch, 2 with dinner, and maybe 1 with breakfast will give you about that 2.5 to 3 grams, depending on the dosage of each specific kind of pill. I put some examples there, but I think the biggest, as I mentioned, downfall is that most people aren't getting to that goal dosage. So weight loss, several different methods to weight loss. As we know, there's, calorie controlled meal plans, there's the Mediterranean diet, there's ketogenic diets, time restricted eating, partial liquid diets, obviously just focusing on calorie expenditure in the form of movement or exercise. So that would be an individual choice as to how we approach exercise with that specific patient based on our assessment.
Excellent. Thank you, Julia. I know we're getting questions, and we're certainly going to take some time to answer them at the end of the talk. Now, moving on to what I think is a very common situation in clinics across specialties, not just in preventive cardiology clinic, which is high triglycerides. So here we have a case where a 68-year-old man presents to our clinic because of a high LDL cholesterol level, but we notice that his triglyceride level is 400 milligrams per deciliter, and he has a history of diabetes, his hemoglobin A1C of 8.1%, and he would also like assistance with managing his triglycerides. Now, how do we manage this patient, and how is this different from the first case where we solely focus on LDL cholesterol reduction? Well, let me start off by talking about the medical side of things a little bit here. So when we think about fasting triglyceride levels, and of course triglyceride levels have to be measured in a fasting sense for the most accurate assessment, when we talk about fasting triglyceride levels, this consensus statement, again from the American College of Cardiology, is extremely helpful. And what it talks about here is our approach to triglyceride lowering. In adults who have high risk, they have established heart disease, and they have fasting triglycerides that are elevated, meaning greater than 150 milligrams per deciliter. And as you can see here, in terms of reducing cardiovascular risk, the primary focus still tends to be on LDL cholesterol as the first step, because that has the biggest evidence base behind reducing risk. That's not to say we ignore the triglycerides. We certainly take them into account, and they certainly have an association with cardiovascular risk. But we don't want to forget about the levers that reduce cardiovascular risk, and LDL cholesterol is one such lever. Now, if someone has persistent hypertriglyceridemia, despite what we think is appropriate LDL cholesterol reduction, then we get into approaches that solely focus on reducing triglyceride levels. So how do we do that? Well, we're going to talk about lifestyle in great detail, but we also do other things. We try to ensure that we control their diabetes, because uncontrolled diabetes leads to high triglycerides, and controlling your glucose levels improves your triglyceride levels. We don't want to forget about secondary causes that are potentially treatable or easily reversible. Thyroid dysfunction and certain medications can raise triglyceride levels. Now, there are 2 medications that can reduce triglyceride levels, but there's some discussion to be had about both these medications. Fish oil, prescription fish oil, for example, highly purified EPA, is now available in several countries. Now, these can reduce triglyceride levels, and there's some data saying that they can even reduce cardiovascular risk in the appropriately selected patient. But we do want to counsel patients on certain things. One is that there is an association between high-dose purified EPA fish oil and increased risk of atrial fibrillation. Now, there has been sort of mention of an association with bleeding as well, although that literature is not as robust as the literature, in my opinion, that associates fish oil with AFib. And then we have fibrates. Fibrates, we know, reduce triglycerides quite robustly. But here's the question. Do they reduce cardiovascular risk? We're going to see the number get better. But what does that mean for the patient's cardiovascular risk? That's a question that a lot of patients are interested in answering. And so we have some data pointing us in the direction that fibrate use solely to reduce triglycerides may not actually move the needle on the patient's cardiovascular risk itself. So this was the permanent trial of pemafibrate, in which individuals with diabetes and multiple risk factors received pemafibrate for triglyceride lowering and did not see a reduced risk of cardiovascular events as compared with placebo. Now, that's not to say that fibrates have no role in modern cardiology practice. It's just that we need to know what we're using it for in each patient. So in adults whose triglycerides are more than 500 milligrams per deciliter, their risk of pancreatitis starts increasing, because at that level, what we're seeing are what they call chylomicrons, which are sort of floating around in the blood and raising our risk of pancreatitis. And so both these medications, fibrates and fish oil, can be very useful in reducing triglyceride levels if they're very elevated, and thereby reducing the risk of acute pancreatitis, which I would argue is as important as reducing anything else. That is a very morbid condition to have. And a big part of this is going to be dietary approaches. Now, these are the dietary approaches, for example, outlined in the ACC consensus statement based on how high your triglyceride level is, including restricting or eliminating added sugar, reducing total fat aggressively, minimizing or eliminating alcohol, which is a major culprit for high triglyceride levels, and really working on aerobic activity and exercise. And then, of course, to really drive this home and get into the nuances of this, referring patients to our nutrition colleagues for detailed counseling. So let me turn it over to Julia again to inform us of some wisdom on this topic.
Thank you, Dr. Suraju. So triglycerides, what are they? They are a blood fat, different than cholesterol. They serve as the body's main source of stored energy. After you eat, calories that have not been used immediately get converted to triglycerides and then stored in our fat cells. They come from the diet, and they're also produced by the liver. And we know that foods that contribute to elevated triglycerides are sugary foods, sweets, desserts, candy, baked goods, also fatty foods. So fatty meats and cheeses, fried foods, fast foods, any refined carbohydrates that have both, fat and carbs, like French fries, one of the American standard favorites, potato chips. And then, of course, alcohol can have a direct correlation with increased triglycerides for those who are sensitive. So, as we would counsel a patient on just general reducing those influences, looking at a diet history would really indicate where we might target our intervention. So really looking at where we're seeing these extra calories coming from. But for those individuals whose triglycerides are very high, we do consider this strict diet for high triglycerides. There's two phases. First of all, if those triglycerides are over 1,000, it's a more strict diet, but it is a short-term plan. And the purpose of the short-term plan is to really see if there's a dietary component that's driving. We know there's a dietary component, but to see to what aggression the diet is affecting these triglycerides. So it looks like a very low fat, low carb diet. Again, and it can be tweaked for the patient by the dietitian, but this is a kind of template that we begin with. About 10 to 12 ounces of lean protein. They're provided 2 servings of carb, but they're not allowed any grains, bread, pasta, rice, or potatoes. Carb is coming from fruit, legumes, lower starchy vegetables like squash, winter squashes, or some plain yogurt, or maybe even some milk, some dairy. 3 added fats. So as most of us know, that's very little amount. That only adds up to 15 grams of added fat for the day, in addition to what is consumed through their other foods. Their vegetables are unlimited, no sugar sweetened beverages, sweets, or desserts, and no alcohol. So this diet is followed for about 1 to 2 weeks, and then it's followed by a 12-hour fasting blood draw to see where those values are. I would say that most of the time the triglycerides can drop by 50% or greater on this plan. So then we have phase 2. This is when we're getting it under 500. They're about the same amount of protein. As I mentioned, it's variable. If I have a 200-pound, 6-foot male, I'm certainly going to give him more than 10 ounces of protein a day. So it's adjusted by the dietitian, but they are allowed more carbohydrates. Still the grain, pasta, rice, or potato is controlled about a cup a day. Again, for larger individuals, it may be up to 2 cups cooked a day, and encouraging whole grain versions here. No refined grains, 5 added fats, unlimited non-starchy vegetables, still avoiding sweets and beverages, still avoiding alcohol. And then this is followed for a little bit longer, about a month, and then another fasting blood draw. And after that, we put them on a maintenance plan. So we're hoping to get the triglycerides down below 300, ideally 250 to 300. Then we try to get them on a maintenance plan. So we may use a carb-controlled meal plan, which is a calorie-controlled plan. We may use the Mediterranean diet. Then we've used these phase 1 and phase 2 to really help pinpoint what may be some of the dietary triggers in this specific patient's diet, and then we'll focus on those and alternatives to those that may have been alcohol or drinks or fatty foods, fast food. Again, we would be able to help pinpoint that through some of the beginning phases of the diet. And then we reinforce a lower carb, lower fat plan that, again, is attainable and realistic for the patient. So it looks different for each person.
Excellent. Thank you so much. So let's move on now to a case which really focuses on a few specifics of dietary counseling. So we have a young man here who presents to our clinic for nutrition advice. He would like to improve his diet, and he's especially worried about processed foods. That's a term that he's heard a lot about. He's worried that he's eating whole wheat bread, cheeses, and pasta occasionally, and that this constitutes processed foods. And he's here with a simple question: how do we counsel this patient regarding processed and ultra-processed foods? And the specific questions this patient may have is, what are processed and ultra-processed foods? What is their association with cardiovascular outcomes? And keeping these two things in mind, how do we counsel patients regarding these? Now, from a cardiac perspective, processed foods and ultra-processed foods have been studied. And this is an example of a science advisory from the American Heart Association regarding the role of ultra-processed foods and their association with cardiometabolic health, which is becoming increasingly prominent in the world of cardiology. And this scientific statement, for example, defines ultra-processed foods, or UPFs, as multi-ingredient food formulations that have an element of industrial manufacturing, cosmetic additives, or food substances of no culinary use or nutritional value. And so they provide us with some concepts here about how to think of ultra-processed foods and what sort of additives may constitute ultra-processed foods, with a nice example at the bottom there, where you have flavored dry roasted chickpeas on one side and plant-based chicken nuggets, which may be sort of advertised and perceived to be healthy, which may, because of their use of food additives or substances of no culinary or nutritional value, maybe more on the ultra-processed food side of things. And this scientific statement, again, just as an example, just to get us grounded and get a framework of what we're talking about here, as a nice table of what's considered less processed and what's considered more processed across different categories of food based on their evidence for heart health, least healthy, moderately healthy, and healthier foods. So a nice sort of initial framework to start discussions with patients. But then let me turn it over to Julia here to really talk about this in a little more detail.
So this ideally is a poll. Hopefully it was set up that way. What percentage of the U.S. adult calorie consumption comes from processed foods? And this is only adult calorie consumption. So we'll talk about the childhood consumption is unfortunately greater. Okay, the voting is closed, and everybody, the consensus is 60%, 66 people voted for the 60%, and that is correct, 60%. So it's over 70% for children, unfortunately. So this is a very important topic, and I think it's there's a lot of confusion around the topic, understanding what is an ultra processed food. We don't have clear guidelines, but we have some guidelines. And then a lot of times I just like to use common sense when it comes to this topic, and just providing a lot of education to the patient on what is considered a whole food versus a processed food, and then what lies in the middle. So this was a study. It was, an umbrella review of the ultra-processed food exposure and adverse health outcomes. And this was the findings. There was nearly 10 million study participants. A diet high in ultra-processed foods increases the risk of death from cardiovascular disease by 50%, the risk of anxiety by 48%. So a lot of us think about death from cardiovascular events, but we don't think about anxiety and how this can affect our mental health. And with levels of anxiety rising, especially in adolescents and children, and just across the board, this is a contributing factor. I mean, multiple contributing factors, but this is an easily modifiable risk factor that we can just change. And I hopefully we can change it, globally, with the food that's being provided to us, but even just in our choices, we can make big changes. And as adults, we can really influence children. So that's really important. So the NOVA classification was developed by researchers at the University of Sao Paulo in Brazil, led by Carlos Monteiro, and the Food and Agriculture Organization of the United Nations had introduced this in 2009. They categorized foods into 4 basic groups based on their level of processing, not just their nutritional content. So this is called the NOVA classification. So the NOVA food classification starts with the green there, unprocessed or minimally processed foods that do not undergo processing, underwent minimal processing techniques such as fractioning, grinding, pasteurizing. So we're thinking legumes, vegetables, fruits, starchy vegetables, grains, nuts, beef, eggs, chicken, and milk. So, minimally processed, we have to process some of those foods to safely eat them, is the way that we think about that, right? And then processed culinary ingredients. So these are obtained from minimally processed foods and used to season, cook, or create culinary dishes. So that's salt or sugar, vegetable oils, butter, and other fats. Okay, again, very simple things that we all need to use from a cooking perspective to enhance the flavor of our foods and cook them. Then we move into the processed foods. These are unprocessed or minimally processed foods or culinary dishes which have been added processed culinary ingredients. They are necessarily industrialized. So bottled vegetables, which I think they mean canned vegetables or jarred vegetables, meats in solution, fruits in syrup, bread, cheeses, purees, or pastes. And then we have those ultra processed foods. These are the ones I like to focus on. These are products derived from foods and parts of foods being added, cosmetic food additives. They're not just culinary, not just in culinary. So breast milk substitutes, infant formulas, that's alarming that those are the first 2 things that are listed. Cookies, ice cream, shakes, ready-to-eat cereal, soft drinks, again, sugary drinks, hamburgers, chicken nuggets, no surprises there. We all know what those are. So ultra-processed food, the health implications, they increase your risk of chronic diseases. We know that. They can lead to obesity and weight gain, premature death, and inflammation. So I think moderation is key. I like to use the 80-20 rule with all my patients. 80% of the time, you eat minimally or unprocessed. 20% of the time, you may have a processed food infiltrate in because you're traveling, you're busy, whatever your lifestyle may, have to include some of these food in moderation, just because of the type of lifestyle we all, have to maintain at. So I would say if you can majority of the time keep these foods out, you're in the clear. So not all ultra processed foods are created equal. So when we think about Soy milk versus cheese puffs, they're both maybe considered in that ultra processed food category, but we know they're not nutritionally equivalent. So I like to look at maybe there are some ultra processed foods that may provide nutrition. So such as soy milk or fortified cereals. So some of those foods can actually give us some nutrition and nutrients and could be considered on a safer standpoint than when compared to some of those very ultra processed foods that contain no nutritional value. So we really need to educate patients on how to make informed choices, and really importantly, bringing meal preparation back to the home. So being able to have more control of what you're putting in your foods. So I'm going to talk about the specific diets. I'm going to briefly go through these. I think most of us know, but I'm really going to talk about the pros and cons, how we counsel patients on these diets and approaches, the risks and benefits, and then of course the details of each diet. Okay, so I want to start off with the PREDIMED trial, the Mediterranean, which covered the Mediterranean diet and health outcomes. So we know that the Mediterranean diet has proven very, very helpful from a cardiovascular risk factor prevention standpoint. It was a randomized control trial done in Spain with 7,400 participants. They were aged between 55 and 80 years old. Population was a high cardiovascular risk, so diabetes or multiple risk factors. The intervention was a Mediterranean diet plus extra virgin olive oil or nuts versus a low-fat diet. The median follow-up was 4.8 years, and the main outcome was that it provided about a 30% reduction in major cardiovascular events, including MI, stroke, and cardiovascular death. Key mechanisms is it lowered blood pressure, improved lipid profiles, reduced fasting glucose, and had many anti-inflammatory effects. So what is the Mediterranean diet? So this is based on, this is a copy of the handout we give our patients at the Cleveland Clinic. And the Mediterranean Diet Foundation came from this PREDIMED study. So fresh fruits and vegetables, no surprise here, 3 servings of fruit, 3+ servings of vegetables a day, 3 servings of legumes per week, which is about a half a cup, fish 3 times a week, ideally fatty, oily fish, poultry, white meat instead of dark meat or red meat, nuts on a regular basis, at least 3 servings per week. Serving size is considered an ounce or 2 tablespoons of a natural nut butter, 2 to 4 tablespoons of extra virgin olive oil, so very generous serving there. Wine, now this is where it can be controversial. Again, if you have triglycerides, we avoid it. I don't necessarily counsel on including or discluding wine. I just say if you are already a habitual drinker, wine is the best choice to make, and not to exceed 1 to 2 glasses in a day. Whole grains, so minimizing any processed grains, so doing grains and starchy vegetables are limited, 3 to 6 servings a day. That's not a ton. That comes out to be maximum a cup per meal. So it's not an excessive amount at all. Very little red meat, about a serving per week or less. Cheese, we're limiting to 3 ounces per week. And then eggs, about an egg a day. Again, that varies anywhere from 4 to 6 yolks per week, depending on the patient's cholesterol profile and medical history. So I'm just going to jump into the DASH diet. So DASH is a dietary approach to stop hypertension. So obviously this would be a diet we'd give with someone with uncontrolled hypertension. It's very similar to the Mediterranean diet. There's a lot of similarities, emphasizes grains, fruits, vegetables, low-fat dairy. It's naturally low in saturated fat, total fat, and cholesterol. It does encourage poultry, fish, nuts, and whole grains, and it reduces the amount of fats, red meat, sweets, and sugary beverages. I would say the biggest difference between the two is that the dairy is a little bit more generous in the DASH diet. Grains and carbohydrates are more generous, and fats are more controlled. And then in the Mediterranean diet, encouraging a little bit more often fish, beans, and healthy fats. That's the overall overarching difference. But the conceptual conceptually, they're both very similar. So there's some key studies here supporting the DASH diet. For the sake of time, I won't review those, but there's several great studies, data, dating back to 1997 that indicates, a lot of good positive outcomes with lowering systolic and diastolic blood pressure, with lowering LDL, with lowering, cardiac injuries, with so many, reducing cardiovascular risk factor, the 10-year cardiovascular risk, so reducing inflammation. So many great studies here to support the use of the diet. So there are meal plans available. As we know, that it reduces cardiovascular risk and blood pressure. And it's been around a long time, so we have a lot of great resources for patients. This is one of the greatest reasons we use it. It has, a week with the DASH eating plan. It has a very robust cookbook and tons of recipes. So there's Pinterest articles and recipes. So there's so many great resources for patients, and it makes it so much easier to follow a diet that has so much support. Now, real brief, carnivore. So the carnivore diet is mainly where you're consuming only meat. So some forms of carnivore will allow dairy, some will allow eggs, some will allow butter, but the foundation is mainly made up of meat. So there are no plant-based foods at all consumed. So no grains, nuts, seeds, fruits, vegetables, legumes, nothing of plant source. So what are the pros? We can rapidly lose weight. It's simple to follow. There's no counting calories. It can improve blood sugar. It can improve triglycerides in the short term. It's high protein, so it sustains satiety, and it eliminates processed carbohydrates and sugars. So the cons, you're exposed to a lot of nutrition deficiencies. So you have lack of fiber, vitamin C, E, antioxidants, so many other nutrients and vitamins. You may have digestive issues such as constipation or gut microbiome imbalances. It's very high in saturated fat, so it can cause LDL to rise, and it can increase your cardiovascular risk. There's limited scientific evidence for its long-term safety, and it's socially and sustainability challenge. It has its challenges there. It's hard to maintain. So we don't necessarily recommend that diet by any means, but then we kind of move into the keto diet, ketosis. So ketosis is that metabolic state when you're switching from burning carbs into burning fat for energy. The fat breakdown produces ketones. Ketones become your body's brain and brain's main source of energy. And then glucose levels decrease. Insulin decreases. Your liver produces more ketones for energy for your brain. So there's a lot of benefits to ketosis. We have rapid weight loss, appetite control. We have blood sugar regulation, cardiovascular effects, lower triglycerides, improved HDL. We have cognitive benefits, efficient brain fuel, and neuroprotective potential, anti-inflammatory effects, and other potential benefits like the blood pressure reduction. So ketogenic diets, the traditional keto is high fat, very low carb, moderate protein. Fat is the primary source of energy. Now we provide protein sparing modified fast as a diet option for ketogenic. And it's a little bit different than the traditional keto because it's low fat and it's very low carb, high protein. So the primary source of energy is protein. So it's muscle sparing. So benefits, both produce rapid weight loss, both provide a lot of benefits from a blood pressure, blood sugar, waist circumference, triglycerides, and inflammation standpoint. But the traditional high-fat keto does not, and may increase LDL, does not necessarily lower it, and it does not spare muscle. So when you have a higher protein intake, it's more muscle sparing. So moving on to intermittent fasting. So intermittent fasting, as a definition, is when you alternate between periods of eating and fasting. This type of eating is described as patterns or cycles of fasting. So there are various kinds of intermittent fasting. Most commonly, the ones that's prescribed in our clinic is time-restricted eating. And the reason for that is many, many reasons, but it seems to be the most flexible, the most feasible for the patient, with the least amount of side effects or negative outcomes. And it produces more of a normal eating habit based on your circadian rhythm, which can have a lot of benefits too for your sleep-wake cycle. So your fasting window is between 12 to 16 hours. You're eating within an 8 to 12 hour window. I do encourage patients to avoid eating 2 to 3 hours before bed. And it is very safe to practice daily if they choose to do so. Some patients may just do it 5 days a week. Some people may choose to do it 3. So there's a lot of flexibility there. And then there are increased benefits to time restricted eating when you're coupling it with reducing processed foods, added sugars, and of course, exercise. So just a nice graphic here from the American Journal of Medicine that shows a comparison of intermittent fasting and calorie restriction. So we know the intermittent fasting centering on time-restricted eating promotes ketogenesis. So it is technically a ketogenic diet as well. It's linked to your circadian biology. Weight loss is pronounced in those with elevated BMIs, and it's promising for long-term adherence. So then on the flip side, the calorie restriction reduces calories, but it does not induce ketogenesis. It does not sync with circadian rhythm, but you do see weight loss across all BMIs. So in the middle, both methods of weight loss improve stress response, lower blood pressure, improve insulin sensitivity, and lower cholesterol. Any questions or discussions? We'll take any questions now. Thank you so much for having us today.
Thank you. Thank you both. That was excellent. Continuing to learn from you, Julia, the NOVA classification, that was new to me. We do have some questions in the chat. Are there any patients that would not be good candidates for taking phytosterol supplements?
There aren't necessarily any major contraindications. Most people, if they do take it, may notice some GI upset. So if they're having a negative reaction, which would say that's the most common I've experienced patients complaining of, we usually just decrease the dosage or, just discontinue depending on how severe, but no other major issues. Now, if someone is on a cholesterol lowering medication, I would not prescribe a phytosterol really. So it's only for those patients who are really trying to lower LDL because they are intolerant to medications or really just are choosing to try to do it without medications on their own first.
Okay, that makes sense. Dr. Shraju, I think this question would be for you. If a patient is taking Repatha to reduce LDL, can there be less focus on dietary controls given the high efficacy of Repatha?
Yeah, it's a good question. I think it depends on the patient. So if the primary goal is to get the LDL cholesterol low for a specific reason like secondary prevention, and you achieve that with Repatha, you could potentially allow the patient to liberalize their diet a little bit if they have been very restricted in terms of their eating. Allow them to have a steak once in a while for celebratory purposes, etc. But what we don't want to forget is that LDL is not the only thing that we focus on for many patients, right? So Repatha reduces LDL cholesterol. It's not really an anti-glucose lowering medication. It's not a triglyceride lowering medicine, and it doesn't lower blood pressure. So diet, on the other hand, as Julia pointed out, has multiple potential benefits depending on the diet you have. So we really want to be careful about allowing or telling patients, hey, you're on the medication, eat what you want. That's a dangerous road to go on for many patients because there are benefits that go beyond what a single medication can offer.
And I would say that's a common misconception. Yeah, I'll commonly see, I know Kate, you probably did too. Well, I'm on cholesterol lowering medication, so why can't I eat 3 eggs a day, or why can't I eat steak 3 times a week? So I think there's that's just a great opportunity to provide education. And we're very blessed to have physicians in preventive cardiology that have such great support to nutrition and value nutrition as one of the key factors to reducing cardiovascular risk.
Excellent. Okay. One other little case study here in the chat. So would you ever consider a statin for a patient with a LDL cholesterol of 150, total cholesterol 224? They've had that cholesterol 10 to 15 years without any other risks, like healthy weight, balanced eating, exercise, no other alcohol, or no other significant medical history. What would you say?
What a great question. What a great question. Honestly, this could be a case in my clinic. So this is not an easy question to answer, believe it or not. This is actually harder to answer than someone who's much sicker, because that becomes black and white, right? So it depends on a few things, right? Depends on their age, depends on their family history, right? Depends on other risk-enhancing factors. For example, do they have autoimmune diseases? Do they have a high level of a high sensitivity C-reactive protein? Do they have elevated lipoprotein little a levels? Right? Is there any reason to look for subclinical disease with a coronary calcium score? So there are all these questions that we need to answer before we de-risk a patient, so to speak. So a word about the risk factors, right? The ACC-ACVD risk score and the Framingham score were mentioned in this question. Such a great question. Those risk factors are very useful at a population level to risk stratify people and say, okay, on average, your risk is of an event over the next 10 years is X%, right? But it has holes. And those are well acknowledged in the literature, including by the people who made the calculators, which is, one, it was derived from certain populations to predict cardiovascular risk over 10 years. So it doesn't really, the AHA and Framingham calculators don't really give you long-term risk prediction. And we're talking about these, we're not talking about a 40-year-old trying to prevent a heart attack before they turn 50. We're talking about a 40-year-old trying to prevent a heart attack for the next 30 years of their life, the next 40 years of their life, right? So using the calculators to de-risk somebody over a long time horizon is risky. I wouldn't use it for that purpose if that's what the patient is interested in. The second thing is, we know that these calculators are not perfectly calibrated, meaning they don't perfectly predict who ends up having a heart attack. There are holes in that as well, right? So what I like to do is to first be very thorough in ensuring that I've looked at every single risk enhancing factor with patients. And the thing that slips by many of us is family history. And so it's very important to take that seriously if they have a family history of premature coronary disease. Then, if there's a motivation to not give them a statin, I would have a low threshold to make sure that they don't have any subclinical vascular disease, especially if they're above a certain age. Like if they're about 40 years old, I might do a coronary calcium score. I might do a carotid ultrasound. I might just prove to myself that I'm not denying this person the chance to reduce their risk by 22% for every 40-point drop in the LDL cholesterol. That's what statins provide. I'm not denying the person that opportunity, and that I'm not making a mistake by not starting a statin early. So I know it's a long-winded answer. It's inherently a long-winded answer because these are the sorts of discussions that take up entire clinic visits. But I hope that's helpful. But the simple answer is it ever recommended anyway? The answer is yes, in many cases. But it requires some audit investigation and discussions with the patients.
Thanks for that thorough response. What about the NMR lipid profile? Would you ever use that?
Oh, good question. Yes. So I like that profile in selected cases, right? So when it comes to lipids, we know that apolipoprotein B concentrations are the best predictors of risk. Now, if you're not going to order an ApoB or it's not available where you are, then a non-HDL cholesterol, like I pointed out at the beginning of the presentation, is the best predictor. If your non-HDL cholesterol is high, you're more or less done as far as the need for lipid lowering goes. What an NMR lipoprotein panel gives you is extra information that can help in certain cases. For example, if someone has metabolic syndrome, right, they have excess weight or they have prediabetes, but their LDL cholesterol is on the borderline, and you're sort of confused as to whether this person needs a statin or not because their LDL is really not jumping out at you, but they have all these risk factors. Then an NMR profile can give you the concentrations of small dense LDL particles, which are high in sort of metabolic dyslipidemia and which are atherogenic. So it breaks the tie. And so if it's high, even though your LDL doesn't seem that bad, you say, no, this is fooling us. This concentration, cholesterol concentration is fooling us. You actually have a lot of particles. And that's the other way it breaks the tie, is it gives you the LDL particle number, which is a better predictor of risk than the particle concentration or the cholesterol concentration. So I use it in a nutshell to break the tie if I have someone who's borderline and I'm not sure, or they're not sure if their risk is high enough to start a statin. I don't order it routinely though, because in most cases, the non-HDL cholesterol of the ApoB beats everything else.
Okay. Awesome. I like that saying, beats a tie. That's a nice way to look at it. Okay, Julia, how do you do a keto diet that's different than a carnivore diet? How much fat, carbs would be included?
Great question. So carnivore would just be meat only, and a keto, which would be more of a protein sparing modified fast, is what I would encourage a patient to do, would include vegetables. So there's unlimited certain vegetables like leafy greens and celery and cucumbers, and then there's limited amounts of the marginally starchy vegetables to about 2 servings a day. And then we're also providing some fats, healthy fats, again, encouraging things like extra virgin olive oil, some nuts, some seeds, some sources of healthy fat to avocado to add back in. So much more nutrient dense and covering as much nutrition, that nutrient basis that you can. Of course, there's supplements included when we follow protein sparing modified fast to cover the gaps that we're not getting through our diet.
Gotcha. Right. So they get that fiber. That's the extra. Yeah. Okay. And then looks like last question, what type of dietary changes can patients make either at risk or with diagnosed CVD that are the low hanging fruit, would you say?
I mean, I'd start with 2 basic things I start everyone with: reducing saturated and trans fat. So we should be eliminating trans fat at this point, and then increasing dietary fiber. So those are 2 very basic low hanging fruits. So most of the time, those 2 goals are always in the back of my head, no matter who I'm counseling. So I might be switching their bacon to turkey bacon. I might be switching their 3 eggs to 2 eggs and 1 white. I might be switching their white toast to whole wheat toast. So everything I do that's the goal, is to decrease their saturated fat and increase their fiber. I may be switching their potato chips with their sandwich to a smile side salad or vegetable soup or a cup of fruit, or whatever we can do to incorporate any type of fiber, whole grain, fruit, vegetable, to get that total dietary fiber up, and then any little changes we can do to decrease saturated fat. So even looking at condiments, cheese, things like that. So those are the 2 basic categories of food I would target.
Okay. Yeah, back to the keto diet. Any fruit allowed on a keto diet?
No, typically no, because the carbohydrate intake for, again, this is variable. For most keto diets are about 20 to 25 grams. Now, some use net carbs, some count total carbs. Again, ours is not counting carbs by any means. It's just providing you what you can have. There is no fruit on the protein sparing modified fast diet that we provide. I know some more marketed keto diets will include some fruit like berries or apples, but for what we provide in the clinic, no fruit.
Okay, I think last 2 questions. Can you give your opinion on butter versus margarine and any specific cheeses you recommend?
Both great questions, very common questions. So I definitely advise butter versus margarine. Margarines are mainly made with saturated and trans fats and processed oils. So if you're going to use one or the other, I recommend a small serving of butter, but I really use that opportunity to educate people on how they can utilize more olive oil in their diet. So a lot of people are using, but I can't have green beans without butter. I'm like, well, why don't we try them with extra virgin olive oil? They taste amazing, right? So it's a matter of, there's certain things that, most people like butter on a sweet potato or whatever. They're specific, or a white potato. There's specific things that people really like to use butter or margarine on. So I try to say, well, what are those things? And let's focus on just using this small amount with only those foods. And let's try to utilize extra virgin olive oil for everything else. So it's more of an opportunity to incorporate a healthy fat versus, honoring one versus the other. So but my go-to is butter if you're looking at butter versus margarine. Unsalted butter, ideally. And then with a cheese, I recommend more mild cheeses, white cheeses. And I just say white because they, most of the cheeses I recommend fall in that category. So things like a fresh mozzarella, a feta, goat, ricotta, cottage cheese, which isn't the cheese that most people are thinking of, but any farmer's cheese, any Havarti or light or Swiss, any of those cheeses that are more mild, have maybe even a little of a lower lactose content because of the way they're processed, and tend to also be lower in fat, and in some cases sodium, depending on the cheese.
Wonderful. Awesome. Thanks for all the great questions, everyone. All right, so I think we'll go ahead and wrap it up. I'm going to toss it over to Renee. Thanks again, both of you. That was wonderful.
Yeah, no, thank you so much. I really appreciated reviewing the case studies and the interventions, and thank you everyone for the great questions as well. I think a lot of good takeaways that I'm hoping that a lot of our participants can take back and use in their practice settings. So really appreciate your time this evening. All right, and mark your calendars. We are coming back in 2026 with 6 new Nutrition Live sessions. So more information to come soon. And as a reminder, there are so many education offerings offered through DDI. So you can visit our website. There's the link, and I believe it's in the chat as well, and then or scan the QR code. And with that, thank you everyone for your participation and for your support of our Nutrition Live series. We hope everyone has a great evening, and wishing all of you a very happy holiday. And we will see you next year. So thanks so much.